When patients have, when their symptoms have progressed to the point where the non-operative means with injections and physical therapy and bracing and medications and activity modification and weight modification are not providing patients relief from an arthritic knee that they're experiencing, then what we have left to offer is a knee replacement. And what happens with that is patients' health is optimized. We make sure they're as healthy as we can have them be by seeing their primary care person. We've developed a preoperative testing center at Concord Hospital where patients come in and we do some specialized tests with some nurse practitioners and nurses to help limit complications. And so patients then come into the hospital the day of surgery. Surgery takes a couple of hours. The thing that's different about knee replacements than hip replacements is, one of the things is that our pain control is much better than it has been in years past. So my anesthesia colleagues typically will give patients a nerve block down around the knee, what we call an adductor canal block, where patients will get a shot of numbing medicine like they might get at a dentist's office. And that's before surgery, before they go to the operating room typically. And that helps patients feel really quite well for a day and a half or so. During surgery, I'll also inject some numbing medicine around the tissues with maybe some other medicine mixed into it, an anti-inflammatory. Give patients some pain pills, orally even before they go to the operating room. And once they come out of the operating room, patients are in the recovery room for about an hour and a half. Then they're up to the regular room on the orthopedic unit where they get up walking typically that day. And patients now have good strength, they have good pain control. They start walking with a walker or crutches just for balance. We don't want them to have a fall or stumble and have something unforeseen happen. And there's a lot of physical therapy after knee surgery. So physical therapy starts in the hospital, much more physical therapy than hip surgery. The knee will feel very tight and stiff. It'll feel like it doesn't want to bend or straighten. And so therapy will start in the hospital. And then when patients go home, many patients will have the home therapist come to their house just to make it more convenient for them until they're up, getting around a little better. Other patients will choose to go to a therapist's office if they're able. Driving a car after surgery is a judgment decision on a patient's part. I think it's reasonable for patients to consider driving when they can use a cane and when they're not requiring narcotic pain medicine during the day. And so everybody's different, whether that's 2 weeks or 6 weeks. And similarly, patients get off of these supports when they're comfortable and confident, and whether that's 2 weeks or 6 weeks, everybody's different. To decrease the risk of a blood clot for a patient with knee replacement, sometimes we'll use a blood thinner called Coumadin, sometimes we'll use just a regular strength aspirin a couple times a day, and some mechanical means or compression stockings to limit that. That varies from patient to patient. Patients come back to see me in the office about a month after surgery, and at that point they're starting to get around pretty well, but knee surgery hurts more than hip surgery. And at that point at a month, the knee will still be quite stiff and sore. It'll feel like it doesn't want to straighten all the way or bend all the way perhaps, and those are all normal feelings for patients at that point. And so many patients will go to a physical therapist's office for a couple times a week for the second month after surgery, sometimes the third. And so the first 6 weeks are typically tougher after knee surgery, and then things start to improve quickly over the second month and third month, and more gradually for a year. So once again, full recovery is a year-long process, but things do improve quickly over 2 to 3 months. We do the surgery for pain relief with the knee replacement. That's why we do it. And once patients have recovered, they typically have much less pain than they did before surgery. But once again, it's not going to be the knee that they had when they were 30. So knee replacements often tend to make noise. They can click and clunk a little bit as the metal contacts the plastic. Sometimes patients can have a sense of a grindy or gritty sensation as some scar formation may occur as they bend and straighten the knee. With a scar over the front of the knee, many patients will tell me they don't like the way it feels to kneel directly onto the scar. Not that they're doing anything to hurt it, but it can be just uncomfortable as they kneel on it. And with a scar over the front of the knee, it's common for the skin to be numb around the scar as well. That skin feeling tends to improve over the course of a year, but it may always feel a little bit different. And the other thing is that patients often describe that the knee just feels tight or stiff, or some patients will describe it feels like there's a band around the knee, even when it moves very well. And my sense on that is that our knee is really just skin and bone and tendons and ligaments, which is very different from the hip replacement, where we have all these big supportive muscles of our buttock and pelvis and upper thigh to support an artificial joint. So when we have not as much muscular support around the knee, it can just feel different and a little tight like this, and that's normal. Activities that are reasonable to do with a knee replacement are similar to those with a hip replacement. Really unlimited walking, swim, garden, golf, mild hiking, elliptical machine, those type of things are good things to do. Again, similar with the hip replacement skiing, where we live in northern New England. If someone's been a very good lifetime skier, I certainly have patients who ski, but of course all activities have risks. And if you take a tumble or a fall or somebody runs into you, unusual things could happen where you'd injure a ligament or break the bone around the implant. So you just want to be careful skiing. Well-groomed slopes, less crowded days. If someone hasn't skied for quite a while or was never a very good skier, then I would discourage those patients from skiing.